Today, I want to talk to you about my evolution in managing SLAP lesions over the past 40 years. I don't really have any conflict of interest to disclose. As an introduction, throwing creates significant forces across the shoulder. I still believe the granddaddy of these injuries is the rotator cuff. If you look at this baseball player on the right with the extreme external rotation on his shoulder and valgus stress on his elbow, you'll understand why there are many repeated injuries to the throwing shoulder in a Major League Baseball player with any longevity. Baseball labral injuries, though, have become more and more common. Actually, the first account of labral surgery in baseball throwers was first reported in 1983 by Dr. Pappas, team physician of the Boston Red Sox, and it was seen in open cases and was called functional instability in his article published in the American Journal of Sports Medicine. That was 1983, functional instability, and it was labeled as lesions of the glenoid labrum that allow the shoulder to catch, click, and lock secondary to partially detached fragments becoming interposed between the articular surfaces. Back in those days, it was treated by an open excision. It was very similar and likened to a torn meniscus in the knee. I began my journey with slap tears in baseball when I first began to scope the baseball throwing shoulder, the late 1970s and early 1980s. At that point in time, there was very little known about the pathophysiology of the baseball throwing shoulder in general. The one common and most frequent pathology that I was confronted with was an injury to the superior labrum. For lack of better terminology, I call that the biceps labrum complex, and I published my first paper on this subject in 1985 in the American Journal of Sports Medicine. This was the article in 1985 in AJSM, and I was the first to describe the biceps tendon complex tears. The hypothesis back then was that the biceps tendon acts to pull the labrum from its superior glenoid attachment during the deceleration phase of throwing. The glenoid labrum tears were related to the long head of the biceps in that article, and Dr. Bill McLeod, biomechanist, helped us understand that there was a 200-pound force pulling the biceps tendon off of its proximal insertion during the deceleration phase of throwing. Dr. Bill Carson also was co-authored in that article. He was a former fellow of mine. Also, somewhere along the way, we did an external stimulation of the long head of the biceps in the operating room using electrodes on the biceps muscle, as you see here. When we stimulated that biceps muscle, we wanted to know what it would do across the shoulder joint. If you look at this closely, you'll see how when it's stimulated, the biceps contracts and pulls the humeral head right into the glenohumeral joint and compresses it. There's also stress placed on the biceps tendon as it inserts through the superior labrum to the superior glenoid recess, as seen here. In that early setting, I was only technically able to debride the slap tear, and the results were pretty gratifying. Along the way in 1990, Steve Snyder coined the term superior labral anterior posterior tears and called it SLAPs. He classified SLAPs into types 1 through 4, and he published that in the Journal of Arthroscopy and Related Surgery. That's where the terminology SLAP came from. These are the 4 types of SLAPs that he published. In the upper left, you see a type 1 SLAP, which is degenerative. Bottom left, you see a type 2 SLAP, which has been pulled off, as you see on the illustration. Type 3 SLAP in the upper right is a bucket handle tear of the superior labrum, as seen in that arthroscopic view and illustration. And when that tear of the superior labrum involving the biceps tendon goes up into the tendon itself, as seen in the illustration on the lower right, it becomes a type 4 SLAP. The mechanism of injury for SLAP lesions has been studied in detail. Steve Snyder had most of his cases were non-throwers, and most of them developed a SLAP from a fall on the outstretched arm. My SLAP lesions were in the overhead thrower. There was also a traction injury series by Maffitt. And then there was the GERD phenomenon, glenohumeral internal rotation deficit by Morgan. And then there was the torsional peelback mechanism popularized by Burkhardt and Morgan. And then probably most important and most telling is weed pulling by Conway. This next slide will show you a weed being pulled out of its attachment to the ground. And you see it, if you pulled on it straight away, it wouldn't come out. But if you rock it back and forth, as seen here, it'll eventually come out at its root. That's what we think happens to the biceps tendon as it attaches to the labrum with repeated internal, external rotation and abduction of the shoulder joint in the throwing motion. That's weed pulling by Conway. Further pathophysiology of the biceps labrum complex has been studied, as we'll show you in this video. This is the peelback phenomenon popularized by Burkhardt and Morgan, and it shows here looking from the back into this shoulder, and you see the biceps tendon as you externally rotate into the cocked throwing position. The whole posterior superior labrum peels off the back of the glenoid rim at the posterior superior attachment. Also, as you look above, you see that there's a subacute tear to the undersurface of the infraspinatus rotator cuff from internal impingement. And that's typical of what we see in the throwing shoulder in about 80 to 90% of the cases. That's a posterior type 2 SLAP with undersurface tearing of the infraspinatus rotator cuff. By the way, SLAPs with a peelback are considered sometimes to be adaptive changes. And some experts say that that's needed as long as it doesn't cause symptoms to allow full external rotation and to be able to throw with high velocity. When it moves from an adaptive change to a pathologic change, though, is somewhat debatable. What about the clinical history? Well, diagnosis of SLAP lesions may be challenging. Symptomatic superior labrum and biceps tendon complex lesions can act like almost anything. And depending on what secondary pathology accompanies the SLAP lesion, a combination of the above-mentioned symptom complexes may be present. So usually there's more than one pathology. In the diagnosis, pain is most common. There may be mechanical changes such as catching, popping, grinding, or locking. There's usually loss of strength, loss of motion, particularly in external rotation, and sense of the arm going out, a dead arm syndrome with loss of velocity. By the way, the history is often more important than the physical exam itself. If you just sit back, prop your feet up, and listen to these throwing athletes and listen to their history real closely, they'll usually give you the diagnosis. The differential diagnosis is also difficult and challenging. According to Snyder, he had a relative low incidence in the non-throwing shoulder, 140 out of 2,300. Now remember, these were not throwers. There were people that fell on the outstretched arm, so obviously he had a low incidence. The symptoms in a SLAP lesion are similar to other shoulder diagnoses. There's always usually associated pathology, partial rotator cuff tears, 29 to 40%. Bankart lesions, 22%. AC arthrosis, about 16%. Glenohumeral chondromalacia, 10%. By the way, only about 28% of the thrower shoulders with SLAPs are actually isolated. So you have to look for multiple pathologies. The diagnosis on exam should first include observation, particularly the scapulothoracic motion. Don't forget to examine for core strength in the lower extremity. Then you have palpation. Usually they're sore when you palpate them posterior superior. They may have loss of range of motion and external rotation, and they may have a tight girth phenomenon also. You need to check for a neurovascular exam. You need to check the neck, and also remember that coexisting pathology can be confusing. My favorite test for a type 2 SLAP is the O'Brien's test. Now, the O'Brien's test can be used for a number of different pathologies. As you see here on your left, with SLAP lesions, it's first done with the thumbs down and about 15 degrees of horizontal adduction. That pinches the superior labrum. And then as you look to your right, if you supinate palm up, the pain will usually go away. In other words, if you have a SLAP, it's usually positive with the thumbs down in the left position. When it's positive, pain is usually associated with the first maneuver that we talked about, that is the thumbs down maneuver. Then it's reduced or eliminated with the second maneuver, as you see in the bottom right, with the palm up or supinated. It's very sensitive, 100%. Supposedly it has a specificity of 98.5%. Sometimes I think that's debatable. It has a positive predictive value of 94.6% when it's positive for a SLAP. And it has a negative potential value, predictive value, negative predictive value when it's negative of about 100%, which means it's 100% that you don't have a SLAP. The question is it reproducible? As I said, it can be positive for other problems about the shoulder joint itself. This is another test that I use. It's called the Biceps 2 test by Kim. And what you do here is you put them at 90-90. You have them supinate, put stress on the biceps tendon, have them contract and hold against you, pulling it out into extension. That apparently causes stress on the biceps tendon insertion and can reproduce the pain of a SLAP. We go to the O'Driscoll test, the dynamic labral shear test, and here we go from 90, a little less than 90 degrees of abduction, 90-90, and we compress the humeral head into the joint, trying to trap the superior labrum. And as you then bring the arm up into the 120, 140 degrees of abduction, you can feel it catch and you can reproduce pain. Now, I have a test called the Clunk test where I lay them supine and do a similar test, trying to catch the superior labrum with internal, external rotation of the humeral head way up by the ear and compress the superior labrum. I call that my Clunk test. What about radiography for SLAP lesions? Well, as with any thrower, you need to get the thrower series, which consists of an AP, internal and external rotation view, an axillary view, and a chromial view, and what I call a striker view. Just so you know what I mean by a striker view, if you look over here on your right, you'll see the striker view is done in the overhead position. And what we're showing here is the thrower's exostosis. And here's the thrower's exostosis that I'm pointing to with the arrow. If you don't get this striker view, you'll miss this thrower's exostosis, which can be associated with a SLAP lesion. What about MRIs for SLAP lesions? Well, MRIs have revolutionized the diagnosis of shoulder injuries, and I say good or bad. However, MRIs continue to get better and better, and we prefer arthro MRIs here at the Andrews Institute. This is a MRI for SLAP lesions utilizing the ABRA view, which is very important in throwers. This is taken in the overhead throwing position, and it is an oblique view, which in the back shows the posterior superior labrum and the undersurface of the infraspinatus, which is a commonly found problem. And then it obliquely goes through the anterior and inferior glenoid rim, and it shows the anterior labrum and the inferior glenohumeral anterior band of the capsule. which is very important for stabilization. So with this one ABRA view, you're seeing two of the most important stabilizing parts of the throwing shoulder. So if you're going to do an MRI in a thrower, be sure and get the ABRA view. The problem, though, is if you want an excuse to operate on a throwing shoulder, get an MRI. Remembering that all SLAP lesions do not cause symptoms and are not all that significant. You must recognize then a good SLAP from a bad SLAP. And if you see this view right here, that's obviously a bad SLAP with a degeneration of the superior labrum and also a complete detachment all the way back to the capsule underneath. That's a type 2 SLAP. These are all SLAP lesions and examples of bad SLAPs. Upper left, you see that it's torn off and goes up into the labrum that you see where the area is. B shows one that's completely detached. C shows one that probably has a bucket handle type 3 SLAP, and then, or it goes up into the biceps tendon. And then D shows a separated, and that's a bucket handle tear on D where the arrow is. Those are all examples of bad SLAPs that need to be either debrided or repaired. An understanding of, as an understanding of SLAPs progressed with time and experience, we all began to follow a traditional treatment protocol. It's changed a little bit through the years, but not that much. From a conservative standpoint, we focus on associated pathology and core strength. The goals of rehabilitation are capsular stretching, rotator cuff strengthening, and scapular stabilization, working also on core strength. By the way, recent studies to report conservative treatment are still very rare. So we don't really have any real good studies where conservative treatment was carried out extensively to see how well they responded to that type of treatment. What about indications to fix a SLAP? Well, number one, you've got to have failure of conservative treatment before you operate on any type of SLAP. And I tell patients the last thing you want is to have your throwing shoulder operated on, so don't jump at it right away. Traditional treatment for type 1 SLAP has always been a debridement. Type 2 SLAPs, traditional treatment is stabilize the biceps anchor and repair the SLAP. Type 3 is excise the bucket handle tear and, if necessary, repair the remaining portion of the superior labrum and the bucket and the insertion of the biceps tendon. Type 4 SLAP is either an excision of the SLAP and the portion torn up into the biceps, or repair that actually. And if it's really bad, you go straight to a biceps tenodesis on a type 4 SLAP. We've also learned that operating on a SLAP in throwers did not always have a great result, unfortunately. My current trend and recommendations are don't have your throwing shoulder operated on unless you absolutely have to. The indication for a SLAP repair in my situation is based on failure of conservative treatment. We also have recognized that in the classification of type 2 SLAPs, that in the classification of SLAPs, that a type 2 SLAP comprises 80 to 90% of SLAPs found in throwers, as seen here in this illustration and this arthroscopic view. What about the arthroscopic technique for type 2 SLAP tears? Well, number one, we do them in the lateral decubitus position. The gold standard is an arthroscopic setup, as you see here, with an arthroscopic type repair. There are 6 points that help guide you in the treatment of pathologic SLAP lesions. Number one, as you see here, identify normal versus pathologic anatomy. These two illustrations here on this shoulder really don't show much of a SLAP. You wonder why we were even in there looking at it. And then number two is treat only symptomatic labral tears. Be sure to also establish an aggressive bleeding bone bed, as seen here on the undersurface of this SLAP, where we burred the bone to get it to bleed and hopefully heal. By the way, the SLAP tears have a very poor blood supply and don't heal very well. And then you use proper multiple anchor placement, and if you're using knots, be sure and tie on the tissue side. We don't use knots anymore, and I'll show you why in a minute. Stay organized. Put your sutures in from posterior to anterior so you don't tie over your knots, and stay organized as you see here, working from posterior superior back toward the biceps tendon. And the surgical team is paramount to get these complex procedures done in a quick and organized manner. If you look on your right, there are 6 hands putting in this anchor to repair a slap. That's what it takes to do it quick and complete and perfect. Then number 6 is know and communicate with your physical therapist. Appropriate therapy is often more important than the surgical procedure itself. I don't know how many times I've said that. So you need to make sure your physical therapist understands what you've done, what technique you've used, and y'all discuss what you're going to do relative to your protocol and your physical therapy. By the way, I'm currently doing mostly debridement, similar to the techniques I used in the early 1980s, instead of a lot of slap repairs. I still do some slap repairs when it's absolutely necessary. Again, I don't operate on the throwing shoulder unless I have to. And when I do a surgical repair, I use the knotless technique of elytrage. This shows a type 2 slap in the upper left that we would repair, and it shows in the bottom left where we used to use knots. And of course, you tie on the recessed side, but even that, when you abduct and externally rotate, these knots abrade the rotator cuff and actually injure it. So we went to knotless anchors that Neil Elytrage popularized, and in the upper right shows those knotless anchors. They eliminate suture abrasion on the chondral surface, synovium in the cuff, and they restore the labrum back anatomically into a meniscoid type of attachment. And they also have cannulated anchors, which provide extra channel from air elements. These new anchors do. So we're going to a knotless type repair when we actually repair our slap. We all know that slap problems are confusing because some high-level throwers, believe it or not, can function with it, and others cannot function with it. That's why you have to go slow with the decision. Just because you see it on an MRI certainly doesn't mean you need to operate on particularly a high-level baseball thrower at the major league level. What about surgical results of slap repairs? When we look at the baseball literature, the return to play to the previous level of competition in the current baseball literature varies from 30 to 75%. So you see it's not the greatest operation in the world. Traumatic lesions in the literature are better than overuse lesions. Apparently pros are better than college, and certainly position players are better than pitchers as far as their results. How about my results? Well, we recently published this article on return to play and outcome in baseball players after superior labral, anterior, posterior type tears. This is a summary of the results in that Andrea Sports Medicine publication. We had 216 baseball players with isolated slap repairs. Isolated, now, that's important. 71% were pitchers. There was a greater than 2-year follow-up in all of them, with a range of 2 to 10 years and a mean of 78 months. 62% returned to play overall. Now, if you look at pitchers' return to play, it was only 59%, not the best in the world. Non-pitchers were better returned to play. 76% of them returned. Only 7.5% had to have a revision surgery or a biceps tenodesis in this group. By the way, in our group, there was no significant difference between high school, college, or professional return to play rates. That surprised me a little bit. The question, though, is do we have the answer to slap lesions? I hate to tell you, but the answer is no. A large percentage still don't heal, especially in throwers. What about slap failures? In most cases, we have moved to subpectoral tenodesis after a failure of a slap repair. By the way, we're still looking for the results on subpectoral tenodesis in throwers, and those results are still coming, but they're not the greatest in the world. So in conclusion, slap lesions are common. They seem to be more and more common now. They do not always cause symptoms. If you want an excuse to operate on a slap, get an MRI. The technical advancements are still needed. I recommend moving toward knotless slap techniques. Unfortunately, a high percentage of slap repairs still don't heal and continue to be a problem. The debridement techniques are still useful and are back in vogue as of recently. By the way, slap results are now more important than ever. So thank y'all very much for allowing me to present this information to you. Thank you.